Hello everyone. So today I will be discussing basic obstetrics. Okay, so let's start it. First, in the basic obstetrics, there is how we will calculate the EDD from the LMP. Okay, so you all know that to calculate EDD from the LMP, we use the Naegeli's formula. But you should know one thing, that the cycles should be regular and the menstrual cycle should be of 28 days. Okay, so cycles should be regular and the menstrual cycle should be of 28 days. Then only we are going to use the Naegeli's formula. Okay, and what is Naegeli's formula? To add 9 months and 7 days in the LMP, right? So all this counts to be 280 days. Now let's see what we will do if the cycles are regular but not of 28 days. For example, a patient gets its monthly cycles every 35 days. Then can we use this Naegeli's formula? No. Naegeli's formula is to be used only when the menstrual cycle is of 28 days. Right? Okay. So now what we will do if the patient has polymenorrhea or oligomenorrhea. In that case, if the cycle is not of 28 days, okay, so in that case, what is a Naegeli's formula? Naegeli formula is that we add 14 days to we add 14 days plus to the 14 days we add 266 days of after fertilization. Okay, so even if the patient has oligomenorrhea or polymenorrhea, then in both the conditions this 266 days of fertilizations will be same. Okay, so now in the 28 days cycle, the ovulation occurs at 14th day, so we add 14 days plus 266 days after fertilization. Now in the polymenorrhea and oligomenorrhea cycle, we will calculate on what day ovulation is occurring, and then we will add 266 days, and that will be our EDD. Now let's see how we do it. Okay, for example, let's take that the case is of polymenorrhea. Okay, now sorry, here we are taking the case of oligomenorrhea. If the cycle was of 38 days instead of 28 days, the cycle is of 38 days. Okay, now as you know that luteal phase is fixed. It's the last 14 days is a luteal phase. So in the 38 days cycle, the ovulation will be occurring at 38 minus 14, 24th day, right? Because the follicular phase it varies and luteal phase is fixed. So in the case of the 38 day cycle, the ovulation is occurring on 24th day. The remaining 14 days is of the luteal phase. Okay, so now we will add 24 days to 266 days. That counts to be 290. We know that 9 months and 7 days, they make how much? 280 days, isn't it? We did in the last slide that 9 months and 7 days make 280 days. Now in the whatever we will get by Naegeli's formula, we are going to add 10 days more. For example, if we get our EDD as 10th October, now by Naegeli's formula, if we get EDD as 10th October, it means if we are adding 288 days to the LMP, we are getting our EDD as 10th October. Now, if we will add 290 days to the LMP, our EDD will be 20th October. It means we have to, the EDD will be 290 days. I hope you understand. Let's see one more example of polymenorrhea. Polymenorrhea is less days of monthly cycle. So for example, it is 21 days. Okay, then the day ovulation will be 21 minus 14, that is on the 7th day the ovulation is occurring, right? So we will add 7 plus 266 days, that comes to be 273 days. Okay, so we know that If in the LMP we are adding 280 days, then it is was coming 10th October. Now, if in the LMP we have to add 273 days, then it will come 3rd October, right? So in this way we can derive the EDD. Okay, so these days lots of questions are coming on the EDD, so that is why I have elaborated it a bit. Okay, so now let us see the what will happen if the patient was using the contraception, or the patient was a contraception failure case, or the patient is having irregular period, or patient conceived in lactational amenorrhea. In all these conditions we don't know when the ovulation has occurred, right? When the contraception fails, when the periods were irregular, or the when it was a lactational amenorrhea, we don't know that when ovulation was occurring, so we can't use the Naegeli's formula. Okay, in all those conditions in which you are not sure when the ovulation is occurring, you are not going to use Naegeli's formula. Naegeli's formula is only for the 28 days cycle and regular cycle. Regular cycles means ovulation is occurring, right? And for more than 28 and less than 28 days, we are using the modification of Naegeli's formula we saw. But if the cycles are irregular, or there is contraception failure or lactational amenorrhea, then we don't know when the ovulation is occurring. In that case, we will take the help of ultrasound. If the patient come to us in first trimester, then on ultrasound we will see CRL, ground rump length. If the patient came to us in the second trimester, then BPT gave us the most reliable EDD. And if the patient came us to a third trimester, then the female length give us the most reliable EDD. And if it is asked, in out of these, which is the best parameter to know the EDD, then it is CRL, no doubt. Only 2-3 days disparity is there, if it is there. Usually there is no disparity. If it occurs also, it is only 2 to 3 days disparity. Okay, so that was all about how to calculate the EDD. Okay, now let us see how we calculate the EDD in the case of IVF cases. In the IVF cases, on day 18 we do the embryo transfer. Okay, so here what we do, we take the patient embryo transfer date. Okay, and in that we know that their pregnancy is of 280 days if the periods are regular, and if it is a 28-day cycle. So in the case of the IVF cases, we don't know period is regular or not, but we know that on the day 18th of the cycle we transfer the embryo. So here what we do is, we on the embryo transfer date we add 262 days. How we get 262? Simple. We know that embryo is transferred on 18th day. 280 days minus 18 is 262. So that is how we get the EDD. Okay. For example, embryo transfer was on 1st October. Okay. So in 1st October we will add at 262 days. Okay, so we don't know how to add 262 days, so we will add 280 days. We know how to add 280 days, isn't it? 9 months and 7 days. So 1st October the 1st October was LMP, then the EDD will be 8th May, isn't it? 9 months 7 days will be 8th May. It will be 8th July. Yeah, it will be 8th July. Okay, now in 8th July we have to minus 18, so it comes to be 20 June. 20 or 21 June, right? So this is how we calculate the EDDs in different scenarios. Okay, we know how to add 280 days. So we see that whether we have to minus or whether we have to plus days, accordingly we do it. So this was all I want to tell you, because these days lot of questions are asked on EDD calculation. Okay, so one question was there in INS set November 22, that one option was there that all the trimesters are approximately of 14 weeks. So here I want to tell you, in the Indian scenario, the first trimester is of 12 weeks, second trimester is from 12 weeks to 28 weeks, and third trimester is from 28 to 40 weeks. Okay, so if we see here, then first trimester is of 12, second trimester is of 16, and the last trimester is of 12. So but the option was approximately 14 weeks. So this approximately 14 weeks is usually done in the foreign international. Okay, in internationally, first 14 weeks is the first trimester, next 14 weeks is the second trimester, and 28 to 42 weeks was third trimester. Now why we don't mark that and why we marked the other option? Because in the another option it was given that EDD is calculated from the last day of the LMP, which is totally wrong. In that question we have to mark what is wrong. Okay, so where we have to calculate it, EDD, we have to calculate it from the first day of LMP. That is why we marked it wrong, because the word approximately 14 weeks was also given. Okay, I hope you understand. Now let's move to the next slide. Now here it is about how to calculate the fundal height from per abdomen examination. Okay, we all know the 12 table. Okay, so when it is at the pubic symphysis, then it is 12 week. When it is at the umbilicus, it is 24 weeks, and when it is at the xiphisternum, it is 36 weeks. So 12 is at pubic symphysis. All the important landmarks you have to go in the 12 table. Pubic symphysis 12 weeks, umbilicus second landmark 24, and the third landmark xiphisternum is 36 weeks. I hope now you will not forget. Okay, now let's move to next slide. Now, in the other signs of pregnancy, you all know there are some signs of pregnancies. We will discuss it again. But what are the other signs of pregnancy than that early pregnancy signs? Okay. So one is internal ballotment. What is internal ballotment? Internal ballotment means that when we do, by doing PV, we put our fingers, two fingers, in the interior cervix. For example, this is vagina, okay, and here is cervix. Somebody here is cervix. So I put my finger in the patient's vagina, and then I touch this interior cervix, and then the baby moved. A pulse of moving of amniotic fluid, and the baby was there. So that is known as internal ballotment. So it does not come before 16 weeks, and it goes after 28 weeks. So internal ballotment is positive only from 16 to 28 weeks. Okay, this ballotment means total moving of the baby along with the fluid is seen only when babies are small, not too small, not too early, but in a medium size, you can say. Okay, so all these values are somewhat near 20 weeks. Okay, so first, internal ballotment means when we are moving our two fingers in the interior cervix. So you all know that uterus and cervix, they are soft during the pregnancy, isn't it? Soft signs are Goodale and Hagar. Okay, we will revise it once more. So when we are touching the most soft part, then our pressure gets transmitted to the fetus very early, that is at 16 weeks. Then second is quickening. Quickening occurs at 18 weeks in the primi gravida. So you can say that what is quickening basically? Quickening is basically the child kicks. the fetal movements. So fetal, it is not that fetus starts moving in 18 weeks. Quickening means mother feels it, the movement. Okay, so mother has to feel on its skin of the abdomen. So mother will feel only when it is something forceful. Okay, so you see that on the soft cervix we are feeling it at 16 weeks. So of course a mother will feel at 2 weeks later, that is 18 weeks in the primary, and it is 2 weeks earlier in multi. Okay, and external ballotment means that we can move the fetus like this, like a ball. We can move the fetus when we're doing the PV, sorry, per abdomen. We can take the fetus this side and take the fetus this side. That is, we can move the fetus as per our direction. So external allotment is PA. And of course, as you know that superficially there are many layers: skin, fascia, muscles. So external allotment will be 2 weeks late. Okay, and what is lightning? Lightning is at 38 weeks. That means that the fetus, it goes down at 36 weeks. Now only we studied that it is at the xiphisternum level. All right, and what is lightning? That it goes at again at the 34 weeks at 38 weeks. So it is because the when fetus head engages, fetus goes into the pelvis, then fetus feels like the fetus has lighten up. There is some space empty below the xiphisternum, so that is known as lightning, and that is at after engagement. Engagement of the fetal head occurs around 37 weeks, so the lightning is felt at 38 weeks. I hope everything is clear to you. So internal allotment means the feeling the fetus movements at the interior cervix is moving the fetus by the movement of the stimulating the interior cervix is at 16. Quickening is the feeling of the fetal movements by the mother is at 18 weeks, and feeling of the fetal movements externally on per abdomen is at 20 weeks. So these all are at 2 weeks gap, and lightning is of course at 38 weeks when the fetus head engages. Little about the different stages. You know that when two gametes fertilize, then it is known as zygote. Yes, when two gametes they fertilize, then it is known as zygote. Now, after zygote, it is a morula. Okay, once this zygote divides into two, then two cells divide into four, four divide into uh, 4 cells divide into 8, then 8 cells become 16 cell stage. So morula is a 16 cell stage. When that structure is 16 cell, then that structure is known as morula. Okay, then is blastocyst. What is blastocyst? Morula develops into a blastocyst. There is an empty cavity like it. Then at the blastocyst stage, the implantation occurs. Okay, and after blastocyst the stage is embryo. Now what is embryo? Embryo is 2 weeks to 8 weeks after fertilization. Please always remember that these all are after fertilization, not before fertilization or not from LMP. These all are 2 week to 8 week is after fertilization. There are some terms we always use. For example, when implantation occurs on the 6th day. It doesn't means that implantation occurs on the 6th day of the LMP. Implantation occurs on the 6th day of fertilization. In a similar way, when I'm saying that embryo stage is up to 8 weeks, it means it is after fertilization. So whenever we are talking about zygote, when we are talking about embryo, morula, all this we talk after fertilization. Okay, always remember these data. Once again I'm telling you are after fertilization. So a fetus is after 8 weeks or beginning of the 9 weeks up till delivery. Fetus stage is the stage which is after 9 weeks up till delivery. Then is infant or baby after delivery. After delivery, the same fetus is known as infant or baby. Okay, so zygote is what is formed after the gamete fusion. Morula is a 16 cell stage. Then that morula changes into blastocyst. Embryo is 2 to 8 weeks after fertilization, and the infant is fetus is from the beginning of the 9 week up till delivery, we call it fetus. And the next is infant or baby is to somewhat we say it after delivery. Okay, next is calories of calories in pregnancy. Now this all data is about what the ICMR says. Okay, this all data is what the ICMR says. Okay, in the Williams the data is bit different. I will also tell you about the Williams, but you have to first see this data, and you have to mark your options as per the 4 options. Okay, I will tell you. Okay, see, as per ICMR, for the sedentary female, the calories to be required per day is 1700 kilocalories per day. And in a moderate, or you can say a working female, the working female is not sitting every time she works, so it is 2100, right? And next is the lady who is doing a heavy work like a labor class work, then it is 2700. Okay, so these are the categories which we have. Okay, so if you are the one like me who forgets very easily, so it is 3 table, 18, 21, 24 is missing, then it is 2700, right? So please don't forget, you just see that it is 3 6 are 18, 3 7s are 21, 24 is missing because labor class has to work too much, so 24 is missing, then it is 2700. Okay, and if the lady is pregnant, then you have to add 350 in each. Okay, if the lady is pregnant, then you have to add 350 in each this kilocalories. And if the lady is lactating, for the first 6 months you have to add 600 kilocalories. Okay, now this was about how you have to adjust the calories as per pregnancy, as per lactation. Now here I would like to tell you, the new guideline says that in the pregnancy, ICMR guideline says you have to add 350, but the older guideline says that you have to add 300. Okay, so that's what I'm telling you. If there's a difference of 50 in the any values in the options values, so don't worry out. Okay, okay, now next is what Williams says. What does Williams does? Williams says here Williams add 200 in every category. Okay, so for sedentary, Williams says it 1900. For the moderate worker, Williams says it 2300, around 2300. And for heavy worker, Williams says it 2900. Okay, and what does Williams say about to add in pregnancy? Here I would like to tell you that Williams says add nothing in first trimester, and in the second trimester add 300, and in the third trimester add around 450. That is what the Williams says. Okay, so the calories requirement for the sedentary worker as per Williams is 1900, for the moderate workers is 2300, and for the heavy labor class workers it is 2900. And Williams says nothing to add in the first trimester. In the second trimester add 300 kilocalorie, and in the third trimester add 450 kilocalorie. Okay, I hope it's clear to all of you. So I have told you what all is the data available. You can adjust your answers as per the options. Yes, of course you have to prefer Williams, but sometimes if you will do calculation as per Williams, like it happened in NEET PG 22, that there was option 300 kilocalories in all throughout pregnancy, and 400 in the first, 200 in the second, so nothing was matching. So we go with the IMR guidelines, that is 300 kilocalories in the throughout the pregnancy. So you have to see the options and judge accordingly. Okay, so let us see the iron, calcium, and folic acid and vitamin D requirements in the pregnancy and lactation. See, in the lactation, all the doses are a bit less than the pregnancy except vitamin A, because vitamin A is teratogenic in pregnancy. Okay, so in pregnancy, all the doses required when the fetus is getting formed, the fetus is growing, it means higher needs of iron, calcium, folic acid and vitamin A is there. Okay, so here then higher needs are required in higher demands are there in pregnancy as compared to the lactation. Okay, so that's why in pregnancy everything iron, calcium, folic acid is required in higher values, but vitamin A is required bit less because vitamin A is teratogenic. Okay, so iron demand in pregnancy is 40 milligram. No doubt we give 60 milligram because in India, iron deficiency anemia is much common. The tablet which we give is of 60 milligram because not all that we give in tablet is absorbed, right? So the tablet which we give in Anemia Mukt Bharat is 60 milligram. Okay, so iron dose required in the pregnancy is 40 mg, and the calcium which is required in the pregnancy is 1000 mg, because 500 mg is already balanced by our diet, so only 500 mg tablet we give. So these are something different, what is required and what we are giving. The iron required is 40 milligram, but we are giving 60 milligram because IDA is very common, and in the calcium requirement is 1000 milligram, and we are giving 500 milligram because 500 milligram is expected to be that it will met by our diets. Folic acid requirement is 500 microgram and vitamin A requirement is 850 mics. Okay, so in the lactation it is bit less iron 30 milligram, bit less folic acid 400 microgram, and calcium is the same, and vitamin A is bit more 950 microgram. So this was question in the INI set, what is required more in lactation as compared to pregnancy? So the answer was vitamin A, not iron, not calcium, not folic acid. So you can say everything which is required in lactation is bit less except vitamin A. Okay, so in iron, the vitamin iron required in pregnancy is 40, calcium is 1000 and folic acid is 500 mics. Okay, now let us see how to calculate the parity index or the GPL of the patient. So much confusions are there regarding this. Just listen to 2 minutes seriously, you will clear it everything. We have devised this was a thing which was given to me by my teachers, and now I'm giving to you. So we never get wrong in this if we follow this trick. Let's see what it is. G stands for gravidum, and gravidum means number of time the lady has got the UPT positive. Now you only tell me, if the patient is twins, then UPT will be positive first one time or two time. UPT will be positive one time only, right? So Gravida means number of times the UPT is positive. So even if the abortion occurs, then also UPT will be positive. So it means in the gravida, you have to include each and every pregnancy, whether it is abortion, whether it is IUD, whether it is less than 28 weeks or more than 28 weeks, whatever it is. So number of time, gravida is number of times the UPT is positive. P is para, number of time the lady has entered the delivery room and delivered fetus more than 28 weeks. So number of time the lady entered the delivery room. Now even if it is a twin pregnancy, the lady will enter the delivery room only once, right? And number of time the lady has entered the delivery room and delivered the fetus or fetuses more than 28 weeks. So even if it is twins, triplets, whatever it is, the lady is going to enter once only in the delivery room to deliver it. So that is, it means even if it is a twins pregnancy and the lady has more than 28 weeks children delivered in the past, it means it is a parity is will be counted. Even if it is twins pregnancy, the parity will be counted one, because lady entered the delivery room once to deliver them. Okay, L is live, the number of the live fetuses she delivered. Okay, so I hope it is clear. Whenever ever you have any confusion, go with this trick, it will help you a lot. Now about the Leopold grips. What are the Leopold grips? Leopold grips are the or the abdominal grips. So first, second and third grip. In the first, second and third grip, my face is toward the patient face. Now if example, this is the patient which is lying down. For example, this pen is the patient. Okay, so this patient is like this. So now this is the patient face. Okay, so my face is toward patient face. All the three grips are done like this. Okay, so first grip is fundal, where the fundus is ending, we do the first grip. Okay, then is the lateral grip. But how we do lateral grip is, we stabilize the fetus by one hand and then we move the another hand and we keep the hands laterally. Okay, then we stabilize the fetus by one hand and we then move the another hand. Okay, so here I told you in both the grips, as you can see, for example, this is a patient lying down. So first I check the fundus by palpating it where the fetus is ending, right? Then I did the lateral grip by first I fix the fetus by one hand and then I move the hand, then I fix the fetus by the hand which is moving and then I move this hand, right? In this way I find out by the lateral grip where the back is and where the limbs are, right? And third is the pelvic grip 1. Leopard grip third is pelvic grip 1 or paw lick grip. Okay, what is this? Basically the fetus is lying like the mother is lying like this and I am my face is toward mother face, see, right? And I am just seeing that the fetal head, where is the fetal head and how much it is engaged. So I'm catching the fetal head like this, see, my hands are like this, see. Okay, now I change my direction. Now my face goes, now I change my direction. Now my face goes toward fetus feet. Now if I will rotate myself, then yeah. Okay, so for example, now I'm rotating the our patient. Now this is patient feet. So now when I will rotate, so suppose I have rotated myself, so now my hands will be like this, because now my face is toward the patient feet. Okay, so you, by seeing the direction of the hands, you can see what grip is this. In after rotating myself, my hands will be like this. Okay, toward the pelvis, toward the, if the tip of my fingers is toward the legs of the patient, it means that my face is also uh, uh, toward the patient legs. That is, it's the last grip and it is done like this. putting the hands in pelvis as it is illustrated there. So that is the last grip. So first I will do all the grips in which my face should be toward patient face like this, and in the last I change my direction and I rotate myself, and then I feel like this. Now my face is toward patient feet. Okay, so these are all the grips. Okay, now I think it is clear to you. So many of you have confused today in the quiz the Leopold grip 2 and Leopold grip 4. Okay, so just by seeing the direction, if my tips of the hand is toward the patient legs or patient feet, it means it is the fourth grip. Okay, and if my tips of the hands are toward the patient and face, it means it is the second grip. Okay. Okay, then it is minimal ANC visit as per WHO. So lot of confusion is there on minimal ANC visit as per WHO. So just you are going to focus here. WHO says that minimum antenatal visits are 8. Okay, but if in case 8 is not in the option and the options are only 2, 3, 4, 5, you have 4, 5, 6, 7, it means 8 is not in the option. Then WHO also says that by the term that focused ANC should contain 4 or minimal ANC visit. Okay, if the focused word is there or if 8 is not in the option, then you have to choose 4 visits. If 8 is in the option and focused word is not there, then you have to choose 8 option. Okay, India government also says that only 4 antenatal visits are must. Ideal ANC visits as the visits which we give in the hospitals, which we ask the patient to come, is 12 to 16. That is one visit every month up till 28 weeks, that is second trimester. Thereafter every one visit every fortnight or 15 days, and in the last month every week one visit is there. That counts to be almost 12 to 16 visits. Now let us study about the placenta. Placenta is something which is formed by chorion frondosum and decidua basalis. So let's see what is chorion frondosum and what is decidua basalis. As you can see in the first structure that this is uterus and this is zygote which has entered. Right now the zygote embedded itself, or morula embedded itself in the bed of the endometrium. Right now this and now the some endometrium is some endometrium this way. The endometrium, the morula has make its space in between that endometrium. So endometrium is also above it and endometrium is also below the morula during the implantation. Such type of implantation is known as interstitial implantation. These days lot of questions have been asked from the basic obstetric. That is why I'm explaining each and everything very clear. Okay, so what is interstitial implantation? Means the implantation occurs in between the endometrium. Okay, for example, if this is the morula, the morula came on the endometrium, and soon after it morula go into the interstitium of the endometrium, and the condition become like this. The endometrium is above the morula and endometrium is also below the morula, like this. Okay, So that's it. So this is known as interstitial implantation. In the last exam, we have been asked that what type of placenta we have. The answer was hemochorial. This time they can ask what type of implantation human beings have. The type of implantation is interstitial implantation. Again, I'm telling you what is interstitial. The endometrium is also above and endometrium is also below. The endometrium which is below is known as decidua basalis. This is the morula. The endometrium which is below, just below this, this is known as, so this endometrium is known as endometrium basalis, and the endometrium which is above this morula is decidua capsularis. As you can see in the diagram also, this is capsularis, right? And the one which is in the periphery is the decidua parietalis. Okay, the one which is below is basalis, the one which is above the morula is capsularis, and the one which is at the periphery is parietalis. Now slowly the this whole our fetus starts growing, and the space between the, you can see that this space between the capsularis and the parietalis, it fuse because the zygote or the embryo is growing, right? So slowly this space totally gets obliterated between the capsularis and the parietalis. Okay, and you know that the around the fetus are the two membranes, amnion and chorion. Okay, so the chorion makes the chorion which is just parallel to the decidua basalis. This chorion, this one which I am highlighting it with purple color, this is the chorion frondosum, and this the decidua which is below the amniotic sac is decidua basalis. So this chorion frondosum and the decidua basalis are the two structures which makes the placenta. Chorion is the fetal part and the decidua basalis is the maternal part. Okay, I hope I made it clear, and now you also know what is interstitial implantation. Okay, now let us see what are the some basic things about the placenta. The weight of the placenta is 500 gram. Okay, and this time in the INR set they have also asked about the diameter. The diameter is 20 centimeter. Its thickness is 2.5 centimeter. It's a hemochorial placenta, as asked in our previous exam. Fetal plate is known as chorion plate. Okay, for example, if this is the placenta, the side which is toward the fetus is known as the fetal plate or chorion plate. Okay, the chorion plate gives out chorionic villi, and side which is toward the uterus is known as decidual plate or the maternal plate or the basal plate. Okay, now you all know that blastocyst has a layer of outer layer called as trophoblast. The trophoblast has two type of cells, cytotrophoblast and syncytiotrophoblasts. The cytotrophoblast, it makes villi, and the syncytiotrophoblasts is basically hormone factory. You know that placenta makes a lot of hormones, HCG, HPL, and all these hormones. So all these hormones are made by syncytiotrophoblasts. Even if they ask you any hormone, on each and every hormone is made by syncytiotrophoblasts. So syncytiotrophoblasts is the hormone factory. The cytotrophoblast, it makes the villi, chorionic villi, and the syncytiotrophoblasts is the hormone factory. HCG, HPL, everyone. So now what are these? This placenta. This is something you can say abnormal placentation. The placenta succenturata. So, other than the main placenta, there is a small accessory lobe, and these two lobes, they are connected by vessels. You can see this is a small lobe and this is the main lobe, and these two lobes, if they are connected by vessels, it is known as succenturita placenta. Now, what happens during the placenta removal? This main lobe comes out and the small lobe is left inside, and it leads to secondary pph or primary pph. Most commonly secondary pph. Involution does not occur properly. Okay, subinvolution, actually there should be subinvolution. Involution does not occur properly. Then it also leads to sepsis. Okay, next it is the another placenta is circumvalid placenta. Now it's slight difficult to understand, but if you will keep your focus here, you will be able to understand. I will tell you. Now in the starting only I told you, yeah, in the starting only I told you this is umbilical cord and here it is the fetus. Okay, now I am telling you about the circumvalid placenta. You all will focus here. There, here is the fetus. This is the fetus. Okay, okay. Now here it is attached by the umbilical cord. Okay, so this is the chorionic and amnion membranes here, right? Right. Now this chorion and amnion membrane, when this chorion gives chorionic villi, these are the villi. Okay, so when this chorion membrane gives out chorion frondosum, I told you gives out villi. When this chorion frondosum gives out villi, as it is given here like this, then this is not known as chorion. This is known as chorionic plate. Okay, now ideally this chorionic villi should be up till here. Okay, here should be also villi. Here villi should also be there. Here villi should also be there. But now this chorionic plate in the circumvalid placenta, this chorionic plate is smaller. It is only up till here. It is only up till here. Okay, it is not going. Ideally, it is also like this. Here also are there chorionic villi. Okay, so but in the circumvalid placenta, here there are no chorionic villi. Here the chorionic plate ends here only. Here there is only chorion membrane and the amnion membrane above it, like this. Okay, so whenever the chorionic plate is smaller than the decidual plate, then what happens is this is the decidual plate, right? Now this decidual plate, this is the decidual plate. Now this extra decidual plate, this is the decidual plate, the decidual basalis. The chorionic plate was smaller than the decidual plate, but this extra decidual plate, what happens to this extra decidual plate is that this extra decidual plate is fold on it like this. Okay, it fold on it like this, right? And these are amnion and chorion, and this is the folded decidual plate. And this folded decidual plate, here there is deposited fibrin and other things get deposited, which leads to the APH and IUGR. Okay, as you can see here in the diagram, that this is the chorionic plate. This is smaller, right? And this is your This is your folded 8 decidual plates. See, it is folding, right? In the same way I told you, it is getting fold. Okay, so this is getting folded. Okay, so when it gets folded, now here there is deposition of in between here there is deposition of fibrin and other materials, which leads to APH and IUGR. Okay, so when is the circumvalid placenta formed? It is formed when the chorionic plate is small. This is the one question. And second, what it leads to? It leads to IUGR and APH. Okay, so these are the one things you can see here. How you will identify this placenta? In this way, there will be some circular ring like things you will see here, right? The another type of placenta is battledore placenta. What is battledore placenta? Battledore placenta is the placenta in which the cord is not inserted in the center. It is inserted at the door or at the margin. Okay. For example, uh, if this is the placenta, then the cord get inserted in the center. But as you can see in the picture, the cord is not inserted here in the center. Ideally it should be like this, but it is not like this. The cord is inserted in the margin. Okay, so this is battledore placenta. The next type of placenta is Velamentous placenta. What is Velamentous placenta? Being asked nowadays, it's asked too much. So just understand this concept of Velamentous placenta. Yes. What is Velamentous placenta? You all know that what is umbilical cord. Umbilical cord is 3 vessels, 2 arteries and 1 vein. These 3 vessels, they are wrapped in Wharton jelly is umbilical cord. What if this Wharton jelly ends up and vessels separate before inserting in the placenta? Okay, usually the Wharton jelly is up till its insertion or up till the umbilical cord insertion into the placenta, right? As you can see in this, right? See this this placenta, you are seeing that this umbilical cord is inserted, is there up till this Wharton gel is there. What if this umbilical cord or is not there? Then the vessels will expose off, right? Vessels will expose off, so vessels will separate beforehand only. So that is what is happening. See here, their umbilical, this was umbilical cord and the Wharton jelly has finished, and these are the 3 vessels, if you can appreciate, 1, 2, and this is a third vessel. Okay, so vessels is separate before or the umbilical cord insertion, and because the Wharton jelly is not sufficient, right? And thereby these vessels, they insert onto the membranes, right? So that is why, because these vessels, they have separated, so these vessels, rather than inserting in the placenta center, they insert in the membranes. That is why you can see whenever they will give you the picture of Velamentous placenta, they will always show you that umbilical cord is dividing into 3 vessels, and they will clearly show you the membranes. See, these are the membranes. Okay, they will clearly show you the membranes. So now, it is clear to you what is Velamentous insertion of cord. Velamentous insertion of cord means that the membranes are that the vessels are inserting or are separating beforehand, and they are inserting on the membranes, right? And now this leads to a complicated situation, Waza Previa. What is Waza Previa? Let me show you. See, normally this is the umbilical cord, okay, and it's there. Now when the vessels separate, you can see that this is the umbilical cord, and the water and jelly has end. Now these are the vasa vessels. Now when the vessels are in the lower segment, then this situation is known as Waza Previa. It's very easy. When the placenta was in the lower segment, above the cervical os, it was known as placenta previa. When the blood vessels are in the lower segment or on the cervical os, it is Waza previa. Okay, now as you can see this, that very easily, because of this separation, this vessels, they come to lie at cervical os. Now, with a slight pressure of the fetus head on this vessel, for example, these are the vessels and this is a fetal head. With just a slight vessel pressure of the fetal head on this vessel, these vessels will tear and it will lead to APH. Now, this time it is the fetal blood, not the maternal blood. Okay, and uh, all these things we have studied in APH, right? So Velamentous placenta or membranous placenta leads to Waza Previa. Let us study in short about HCG. It's a very important. Many time, I think 5-6 time they have asked the question on on its composition, glycoprotein. This time also in INI set they have asked what is its composition. It is glycoprotein, glycoprotein. They will keep asking till you remember. Okay, so always remember HCG is a glycoprotein. Okay, it is peaks at 8-10 week. HCG is secreted by syncytial trophoblast. It has luteotropic effect, that is its effect is similar to the LH, because HCG has two units, subunits, alpha subunits and beta subunit. Beta subunit of HCG and LH is same, and also the alpha subunit is similar up to much extent, not totally similar. So HCG functions like LH. Okay, so that is why it is known as HCG has luteotropic effect. So it has been asked like this: HCG structurally and functionally similar to FSH, LH, TSH, and other hormones were given. So beta sub unit of FSH, LH, and TSH, all these three hormones are same, is similar to HCG, but only the function of HCG and LH is same, so the answer is LH. That is why it is known as it is luteotropic effect. Now HCG, because of its LH-like action, it stimulates the male fetus in early pregnancy to make testosterone, or male testes to make testosterone in the intrauterine life, right? It meant this was a question in the NEET PG 22. Okay, so what stimulates a male fetus to make testosterone, a male testes to make testosterone in the intrauterine life? So it is HCG because of its luteotropic effect. Okay, then HCG doubles every 48 hours, and HCG value increase in the Down syndrome. HCG is detected by UPT method, in which we use the ELISA method, and the best HCG method is the radioimmune assay. HCG is known as the sweetest hormone because it has the highest glucose content. I hope every point about the HCG is clear to you now. Next is about the HPL. It is very easy to learn about the HPL. HPL has insulinase-like action, and that is why this action of HPL is at peak at 24 to 28 weeks. The HPL action of the insulinase action of HPL. That is why pregnancy is known as diabetogenic state. It is the hormone which has fastest rate of production, 1 gram every day. It is also secreted by syncytial trophoblast of the placenta. The macrophoid cells of the placenta is known as Hofbauer cells. The layer of the fibrinoid degeneration between the endometrium and the myometrial junction is Nita-Bush layer, and if it is absent, this fibrinoid degeneration layer is absent, then then the placenta form will be placenta accreta. Because if this layer is present, then placenta, because the degeneration layer is there, then placenta separates easily, and if it is not present, then the placenta cannot separate easily. Okay. So the other hormones which are synthesized by placenta is estrogen, progesterone, and relaxin. Relaxin is synthesized by both corpus luteum and placenta, and only in pregnancy. Okay. The other hormones synthesized by the placenta are estrogen, progesterone, and relaxin. I think estrogen, progesterone, you all know. Estrogen synthesized by placenta is known as estriol. Not going into much detail in the amniotic fluid chapter, I only want to tell you the source of amniotic fluid after 20 weeks is fetal urine. Please make a concept. In YouTube, there are I think 2 or 3 videos कि बच्चे के आसपास जो पानी होता है वो और कुछ नहीं, बच्चे का यूरिन होता है और बच्चा अपना यूरिन खुद ही पीता रहता है. ये दोनों बातें सच हैं. Translating it into English, lot of YouTube videos are there that the fluid around the fetus is nothing but the fetal urine, and fetus drinks its own urine in the intrauterine life. And yes, this both the things are 100% correct. After 20 weeks, the amniotic fluid, the major part of the amniotic fluid is nothing but the fetal urine, and the fetus continuously swallows its urine, and thus the circulation of amniotic fluid is maintained. Okay, now the oligohydramnios. This amniotic fluid is less. Okay, so whenever there will be bilateral renal agenesis, that is, urine is not formed, not the unilateral renal agenesis, we have discussed it already in the telegram. Bilateral renal genesis, if both the kidneys are not formed, then only urine will not be there, or there will be urethral obstruction is there. In that case, there will be oligohydramnios. Okay, and if there is placental insufficiency or IUGR, then again you all know that our body prefers to give the main blood to to the brain and to the heart. Whenever there is deficiency of blood, our body circulates more blood to brain and more blood to the heart, right? And that is why the renal blood flow is decreased, and there is decreased urine production. So in IUGR or placental insufficiency, there is decreased urine production. In the premature rupture of membrane, yes, there is amniotic fluid leakage, and again there is less amniotic fluid. Postpartum pregnancy, yes, after at 40 weeks the amniotic fluid is 600 ml, and at 42 weeks the amniotic fluid normally is only 200 ml. So you can see there is a much decrease in amniotic fluid after 40 weeks. Okay, so these are the 4 reasons why there is oligohydramnios. So these reasons you have to remember by heart. Renal anomalies, or urethral obstruction. Number 2 is placental insufficiency, prom and post-dated pregnancy. Okay, the cause of polyhydramnios, as I already told you, that the fetus drinks its own urine or swallows its own urine, and that is how amniotic fluid circulation is maintained. Okay, so now in the case of polyhydramnios, when there will be polyhydramnios when the fetus is not able to swallow its own urine. For example, in the case of the cleft lip, in the esophageal atresia. So most common anomalies leading to polyhydramnios is GIT anomalies, because fetus is not able to swallow its own urine, which was happening normally. There is a swallowing defect in the case of the GIT anomalies, and that is why the polyhydramnios occurs. Okay, so now next is in the neural tube defects. In all the neural tube defects, basically there is exposure of the membranes. This membrane exposure leads to the transudation of fluids into the amniotic sac, leading to polyhydramnios. So in anencephaly, spina bifida, all these cases of neural tube defects, there is polyhydramnios. So the most common anomaly leading to polyhydramnios is no doubt GIT anomaly. The second most common anomaly leading to polyhydramnios is neural tube defects. In the case of the twins, there are two fetuses. There is double urine production. So that is why there is polyhydramnios. In the case of the hydrops fetalis, there is, you all know that patient has heart failure and the patient goes into the swollen stage. Okay, and in the diabetes, due to the hyperglycemia, the patient has increased urine, the fetus has increased urine production. So we can give indomethacin to the fetus if there is a significant polyhydramnios. 75 mg TDS, no need to learn, but it is to be given before 32 weeks. If it is given after 32 weeks, then, and any time, as you know, after 32 weeks the delivery can occur, especially in the case of polyhydramnios, preterm deliveries occur, isn't it? So the after 32 weeks, please don't give indomethacin. It will lead to premature closure of ductus arteriosus. There is a ductus arteriosus. If we will give indomethacin, it will premature close, and if it will close, the fetus will go into pulmonary hypertension and fetus will die. Okay, so after 32 weeks, if the patient has polyhydramnios, we can go for therapeutic amniocentesis. Okay, and we can also go for controlled ARM. What is controlled ARM? With the needle we do the ARM, and very slowly the amniotic fluid comes out. Okay, that is controlled ARM. Okay. Next slide is about the color of the amniotic fluid. Okay, the color of the amniotic fluid in a premature or at around 32 weeks, it is totally transparent water like color. As you know, after 32 to 34 weeks, the amniotic fluid, it decrease in amount. Maximum amniotic fluid is just 32 to 34 weeks, isn't it? So after 32 to 34 weeks, the amniotic fluid starts decreasing in amount, and as it starts decreasing in amount, the amniotic fluids become slight yellowish, that is known as pale color or straw colored. Okay, they often confuse you in exam by telling it is a milky color. It is not a milky color, it is slight yellowish. You can say creamish, pale or straw colored. Green colored amniotic fluid is in the case of meconium stain liquor. The golden yellow color amniotic fluid is in the case of RH incompatibility. because whenever there is intrauterine fetal anemia, then the fetus has jaundice. Similarly, in the RH incompatibility, the fetus has anemia, and fetus has hemolytic anemia, and fetus has jaundice. So whenever there will be jaundice, you know that in jaundice the skin is yellow and the urine is yellow, so the amniotic fluid will also be yellow, because amniotic fluid is nothing but fetal urine. In abruption, there is tear of the spiral arteries, so there will be the amniotic fluid will become red in color or maroon in color because of the deposited blood. In the case of IUD, the in the case of IUD, the because IUD fetus is in a lot of distress. Many times that fetus has have passed the meconium. Okay, right? Because such a fetal distress was there that the fetus expired, fetus died, right? So it means many time whenever the fetus is in distress, you know that fetus passes meconium. So before the death of the fetus, many time the fetus must have passed meconium. And you all know when the stools are kept for long time, which color it becomes, dark brown or tobacco juice color. So that is why IUD is tobacco juice color. Maximum amniotic fluid is at 32 to 34 weeks. Okay, so the amniotic fluid, if one option is there, then you have to choose 32 weeks. Okay, and the amniotic fluid at this range is 1 liter, more than 1 liter. At 36 weeks it is around, actually these all are ranges. Yeah, at 36 weeks, it is 1 liter to 800. At 40 weeks, it is 800 to 600 ml. And at 42 weeks, it is around 200. So, there is significant reduction of amniotic fluid after 40 weeks. That is why we say if on the ultrasound you get oligohydramnios, please rule out post-datism. Our next topic is ultrasound in OBS. So what we want to discuss here in ultrasound in OBS is, yes, ultrasound in OBS says 4 week 3 days, right? On 4 week 3 days, you can say 4 plus week, we get gestational sac. Okay, yes, 4 plus week or exactly at 1 month, you can say we get gestational sac. And on we get this sac at transabdominally at 1 week. At the 5th week, every week we are getting something. After a few days, at 5th week, we get the yolk sac. And after 2-3 days we get the cardiac activity. So you have to remember, and it's a bit obvious to remember, that first gestational sac will come, then yolk sac will come, and then the cardiac activity will come. Okay, so it's just like that. 4 week 3 days, 5 weeks, and 5 to 6 weeks is the cardiac activity. Okay, so you know that cardiac activity will come only once the yolk sac is there, because yolk sac gives the nutrition to the fetus. What are the signs of pregnancy on ultrasound? So here I would like to tell you the earliest sign of pregnancy on ultrasound is endometrial thickening. Okay, so it is endometrial thickening. The intradecidual sign is in the intradecidual sign in the case of the what pregnancy is nothing but gestational sac. Intradecidual, within the decidua there is a gestational sac like this. It is gestational sac is known as intradecidual sign. Double decidual sac sign means the decidua is seen in two layers, two sacs, decidua capsularis and decidua parietalis. As we have already studied in the placenta when we were studying that the you can see here this is the deciduo parietalis sac, right? And another sac which I will be drawing is this is the another sac, and this is the deciduo capsularis sac. So the double decidual sac sign. So we when we make reports, we say we write a DDSS scene. What is DDSS? Double decidual sac sign scene. Okay, that is DDSS. So DDSS is formed by decidua capsularis and parietalis. What is double blab sign? Inside the gestational sac, there is inside the gestational sac there is two sacs. One is amniotic sac and the another is yolk sac, right? One is amniotic sac and another is yolk sac. This both sacs are known as blebs, two circles, as you can see in the picture here also. This is the first circle. See, this is the first circle and this is the second circle, right? So these are the two circles, okay? The one which is attached to the gestational sac is the, of course, the amniotic sac, and the one which is much superficial is the yolk sac, okay? So it is the amniotic sac and the yolk sac, and both these are inside the this outer circle is the gestational sac, okay? Okay, gestational sac, this outer circle is in the gestational sac, and it is between the in between the gestational sac are these two blebs, the amniotic sac and the yolk sac. So ideally in a pregnancy we do four scans. One first scan is also known as dating scan, and as I already discussed you, CRL is the best parameter to date for knowing the EDD exception expected delivery date. It is done at 6 to 8 weeks. The NT-NB scan, this was a question which was asked in INSET November 22. Much high chances it is asked to you also. NT-NB scan is done at 11 to 13 weeks. Okay, students, same is the time of chorionic villi sampling. Okay, anomaly scan is done at 18 to 20 weeks. Same is the time, and amniocentesis is done after 15 weeks. The chorionic villi sampling time and the NT-NB scan is same, but the anomaly scan time is 18 to 20 weeks, but the amniocentesis time is after 15 weeks up till 20 weeks. Okay, so okay, next is the basics of fertilization. Okay, what is basics of fertilization? That after the fertilization on the zygote, during the fertilization zygote is formed. Okay, now after the Yes, after the fertilization on the day 4, the as the day 4 is there, reaches the you all know that fertilization occurs in the fallopian tube. Then this zygote in the form of the morula, it reaches a uterine cavity at day 4 when the zygote has become the morula. Okay, so basics of fertilization and implantation, what is it? That this zygote, yeah, this fertilization which has occurred in the ampulla, this zygote, it this morula, it enters the uterine cavity in a morula stage. Okay, day 6 to 9, day 6 to 9 in in the from day 6 to day 9 after fertilization, the implantation occurs. Okay, and on 11th day, a the uteroplacental circulation is established, and on the 21st day, the fetoplacental circulation is established. I keep on telling you these things because it is very, very important. Okay, uteroplacental circulation is established on 11th day, and on 21st day, the fetoplacental circulation is also established. Okay, the embryo reaches, or the you can say the morula reaches the uterine cavity at day 4 after fertilization, and at day 6 to 9 the implantation occurs. So I already told you, when we are saying fetus, when we are saying zygote, when we are saying morula, when we are saying embryo, we are telling it with respect to, we are telling it in relation to the fertilization days. These all the days are in the now let us see what are the physiological changes in pregnancy in the hematological system. When we were studying, we just were told that hemodilution occurs. Okay, so here I would like to tell you that, and that we all make kheer in our home. We all make kheer in our home. What is kheer? Milk and rice. In the similar way, blood is made up of plasma and RBCs. Okay, in the pregnancies, RBCs increase is 20%, and but the plasma increase 40%. So there is blood dilution. Why there is blood dilution? The blood dilution is there because the RBCs has increased less and plasma has increased much more. Okay, plasma increases 40% and RBCs increased only 20%. So there is hemodilution. Okay, so the increase in the HB, there is increase in the HB mass. Yes, there is increase in the HB mass. Okay, but there is no increase. I'm sorry, there is increase in the HB mass, but the total HB concentration, it decreases. When we say its HB is 11, its HB is 12, it means that this much HB is present in deciliter. It means we are talking about, note the HB concentration. So the HB concentration, it falls, but the total HB mass, it increases. Okay, what is hematocrit? Hematocrit means RBC volume upon the packed cell volume. So as you know that RBCs have increased only 20%. So in short, there is decrease in the hematocrit. Okay, due to all these things, there is also increase in the reticulocyte count. Due to the pathological anemia, there is decrease in the there is increase in the reticulocyte count. Okay, all the clotting factors they increase except 11 and 13. Many times on this small line question has been asked. Please learn this line by heart. All the clotting factors, including fibrinogen, are increased except 11 and 13. It's very easy to learn 11 and 13, right? If because the fibrinogen has increased, that is why there is increased in the ESR. Please mark this question correct next time. It's very, very simple funda. All the clotting factors are increased in pregnancy. That is why, except 11 and 13. 11 and 13 we can easily learn. Because fibrinogen is also increased, that is why the ESR is also increased. Let us talk about the globulin and albumin or the proteins. In the hematological system, the RBCs increased, but the HB concentration decreased due to the hemodilution. In the similar way, in the proteins also, there is increase in the total proteins, but the protein concentration decreases, just as in the case of the hemoglobin. The total RBCs they have increased, but there is decrease in the HB concentration. In the similar way, the total proteins increase, but in the protein concentration it get decrease. Now there are mainly two proteins in our body, albumin and globulin. The albumin protein is usually more, not in pregnancy, in a normal female. Okay, but in pregnancy, you know, गोलू गोलू बच्चे आते हैं, है ना, गोलू गोलू बच्चे आते हैं. So globulin increases, okay, and the albumin decreases. So reverse happen. So I always remember it like this, that the globulin increases and the albumin decreases, because in pregnancy there are golu molu bachches. Okay, so in the normal lady, albumin by globulin ratio is 2:1, but in a pregnant lady, due to the decrease of the albumin and increase of the globulin, the albumin globulin ratio is 1:1. That was what which happens to the hematological system, and the WBC it rises and platelets decrease. Okay, the WBC rises and the platelets decrease. Okay, once again, RBCs increase by 20%, HB mass increase, but due to increase in the plasma by 40%, the HB concentration and the hematocrit decrease. Okay, there is increase in all the clotting factors except 11 and 13. Due to increase in the fibrinogen, there is increase in ESR. The WBC also increases and the platelets decrease. The total proteins increase and the protein concentration decrease. The globulin increase and albumin decrease. Let us go to the CVS changes in physiological changes in the pregnancy. As we discussed now only, that there is hemodilution. Due to the hemodilution, the cardiac output it increases. Okay, because the whatever the increase is there, the blood volume that has to be pumped from the heart. So increase in the blood volume will obviously lead to increase in the cardiac output. So the formula of cardiac output is heart rate into stroke volume. Along with the increase in the cardiac output, the heart rate also increases and the stroke volume also increases. Because the heart rate increases, there is increase in the pulse rate also. Okay, post the more is the increase in the cardiac output, more is a danger to a heart diseases patient. Okay, cardiac output is maximum increase at 28 to 32 weeks, because at this time the blood volume is increased maximum. So the cardiac output is maximum at 28 to 32 weeks. Okay, and the post part and during the delivery there is much more increase in the cardiac output as compared to the antenatal period, because in delivery lot of contractions are there. Okay, so the cardiac output increases a lot, powerful contractions are there in the delivery. And just after the delivery, because the placenta separates the all the blood which was there in the placenta, it enters the fetal circulation, sorry, in the maternal circulation. All the blood in the which was in the placenta, after the spiral arteries they contract, the blood enters into the uterus, and all the blood which is in the uterus, it enters into the maternal systemic circulation. So postpartum there is much increase, so the risk of the heart failure is much more in the postpartum than in the delivery, than at 28 to 32 weeks. Okay, so yes, if they ask you what at in the antenatal period the maximum risk is at, then of course you have to say in the antenatal period the maximum risk is at 28 to 32 weeks. As you all know, there is increase in the cardiac output, right? So where will this increased blood volume go? It has to be in the vessels. So the capacitance vessels, because they are known to dilate, so these capacitance vessels they dilate due to the progesterone, and they accommodate the increased blood volume. Okay, and due to this capacitance vessels dilatation, there is decrease in the peripheral vascular resistance. Okay, peripheral vascular resistance they decrease, and due to this there is systolic bp also decreases. Okay, now the cvp is same, central venous pressure remains same. Okay, are you getting it? Due to this decrease in the peripheral vascular resistance, the pregnant lady keeps on having the syncopal attacks. Okay, in early pregnancy. In the full term pregnancy, uh, when there is not much change in the cardiac output after 28 to 32 weeks, rather the cardiac output decreases, and the body get adjusted to this peripheral vasodilation or peripheral vascular resistance decrease. Then at the full term the fetus starts compressing the inferior vena cava, which is known as supine hypotension syndrome. Many time the examiner confused to you writing their superior vena cava syndrome. No beta, when a mother is lying down at the full term, the fetus gives pressure to the inferior vena cava. Superior vena cava is above heart, right? So how a fetus can give pressure on superior vena cava? A fetus cannot give pressure on superior vena cava, right? A fetus always press the inferior vena cava, because fetus is in the abdomen, so it can only compress inferior vena cava. Okay, so in the early pregnancy, due to the decrease in the peripheral vascular resistance or due to decrease in the systolic bp, the mother has syncopal attacks. But and in the late pregnancy the mother has syncopal attacks because of supine hypotension syndrome. When a mother lies down, the mother is supine in position, then a mother has syncopal attacks. Okay, and in the early pregnancy, throughout, when the mother is lying down, when the mother is standing, anytime the mother keeps on having syncopal attacks due to the decreased peripheral vascular resistance. And in the full term, only in the supine position the mother has syncopal attacks. The central venous pressure or the jugular venous pressure remains same in the pregnancy, remains same. Okay, peripheral vascular resistance, it decreases, but central venous pressure remains same. So here I would like to tell you, in a pregnant lady, if central venous pressure is increased, it indicates that the patient is having heart diseases, because central venous pressure is same in a non-pregnant lady, in a pregnant lady, but if it has increased, it clearly indicates that it is a heart diseases patient. The S1 sound of the heart is loud, S2 is normal, and S3 is heard. The two murmurs which are common in pregnancy are continuous murmur and systolic murmur. Due to the increased blood volume, this murmur comes. Once again, the S1 sound, due to the increased cardiac output, it gets loud, S2 is normal, and S3, we hear the S3 due to increase in the cardiac output. Due to increase in the cardiac output, there is continuous murmur or systolic murmur. Okay. Then there is what are the changes in the respiratory system. The changes in the respiratory system is that all that what increases is ICTV movie. Inspiratory capacity increase, tidal volume increase, and the minute volume increases. All are the factors which increase. The factors which are constant are IRV. I stand for inspiratory reserve volume. V stands for R stands for respiratory rate, and V stands for vital capacity. Now here I would like to tell you that because of progesterone stimulates the respiratory center, so the pregnant patient has deep breathing, because there is increased CO2 sensitivity. Due to this, the patient goes into respiratory alkalosis. I always forgot in my exam that whether it was respiratory alkalosis or respiratory acidosis. I always knew this concept. I don't forget this concept that progesterone stimulates the respiratory center and there is increased CO2 sensitivity. Okay, so here I would like to tell you that I always remember this concept that whether there is respiratory alkalosis or acidosis by the fact by line रस्ते में अलका है, रस्ते में अलका है, respiratory alkalosis. Okay, रस्ते में अलका है, रास्ते में अलका है, respiratory alkalosis. What happens is that increased progesterone stimulates the respiratory center and increases CO2 sensitivity. So there is increased CO2 removal and that leads to respiratory alkalosis. Now let us see what are the changes in the renal system. As you know that all the blood flow have increased, so the renal blood flow also gets increased, which leads to increase in GFR. And the increased GFR lead to increased clearance of urea, uric acid and creatinine. Because there is increase in renal blood flow leading to increase in GFR and increased clearance of urea, uric acid and creatinine. So there is decrease in serum creatinine, serum urea and serum uric acid because of their increased clearance. Okay. Now let us study about the folic acid supplements. Folic acids, as you all know, folic acid supplements, they prevent the neural tube defects. So if there is no history of any neural tube defect baby, fetus, then the dose is prophylactic dose. It is 400 mics per day, and it is given as the women start thinking of conception and up till first 3 months. Okay, or you can say 1 month before and first 3 months of pregnancy. If there is history of neural tube defects, then the dose is not 400 mics, then it changes to 4 milligram per day. The dose of the folic acid to be given along with the iron tablets is 500 mics, as already discussed. In India, most common anemia is dimorphic anemia. So we give iron and folic acid both from the fourth month. The iron dose which we give is the 60 milligram per day in the anemia Mukt Bharat, and the folic acid dose there is 500 mics. Okay, now here we will be discussing the different signs of pregnancy. Okay, so basically these are the 5 changes which occurs in the pregnancy. One is the all the reproductive organs, the cervix, the uterus, and all these structures which are very firm, they get soft. And due to the increased vascular supply, there is bluish tinge in this. During the pregnancy, there is increased vascular supply, so there is bluish tinge in them due to the increase, or bluish or dusky coloration. Bleeding sign, you all know that placenta gets implant, so sometimes there is a bleeding sign there. Okay, then there is a pulsation sign. This increased blood flow, when we will put the hand at the site of the arteries, we can feel the increased pulsation due to the increased blood flow. As fetus is a foreign body, so continuously after the conceiving, there are some contractions in the fetus which is known as Braxton Hicks contractions, and we can feel that contractions also. Now let us see what are the signs. First of all, we will discuss the softening signs. Okay, here in the image, the doctor is eliciting the Hagar sign. Hagar is softening of isthmus, and Goodale is softening of cervix. Okay, so how we will remember that Goodale and Hagar is softening sign? So that is, we always say that whenever we want to pass good stools, the stools has to be soft. So in Hindi or language, stools passage is known as hagna. So good hagna है तो soft होना ही पड़ेगा, उनको soft होना ही पड़ेगा. So good Hagar softening signs. Okay, here they are checking the isthmus is soft or not by manual examination. Okay, now as I already told you, there is bluish tinge. The bluish tinge or dusky hue is due to the increased blood supply. Okay, now here I would like to tell you that the you can see that here there is bluish tinge, and here this is all is bluish tinge. If the vaginal walls are blue, then it is known as Jacquemer signs. As you all know that bright color, the fluorescent colors are known in Hindi as jatak. क्या जटाक कलर पहना है ना, ब्राइट कलर्स. सो जैक्वेमर मीन्स जटाक, एंड चैडविक sign means bluish tinge of the cervix. So this walls, when they are in the bluish color, this is known as the Jacquemer sign, and when the cervix is blue, then this is known as the Chadwick sign. Okay, last is the pulsation sign. As I already told you that pulsation sign, when there is increased blood flow, so there is increase in the pulsations. So Osiander sign is filled. Osiander means dhak dhak. दिल के अंदर, उसके अंदर जाके देखो उसको कितना दर्द हुआ. सो दिल के अंदर जाके. सो व्हाट इज इट? व्हेन वी डू द पीवी इन द लेटरल फॉर्निक्स वी फील द पल्सेशन. ठीक है. सो दैट इज द ऑसिएंडर साइन. नाउ वन साइन which were left is the bleeding sign, right? Bleeding sign. So what are the bleeding sign? The if the bleeding occurs on the day of the LMP, 1 month after LMP it occurs, it is known as placental sign or Hartmann sign. Okay, if the patient has clotting or bleeding on the very same day the patient had LMP 1 month later, then it is known as placental sign or Hartmann sign. And if you ask the lady will surely tell you that her heart fails when she saw that spotting. It looked to her as if it has been abortion. Okay. So contraction signs is known as Palmer's sign. As I already told you, these are Braxton Hectic contractions in response because fetus is a foreign body. So in response to that foreign body, the uterus keeps on contracting. Similar contractions also happens in fibroid and copper T. So we can feel that both contractions when we when we take the uterus by doing biomass